I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Welcome, everyone, to the July 2016 PRS Journal Club podcast. I'm Amanda Silva, and I'm joined by my fellow PRS resident ambassadors, Sammy, Sinno, and Raj Sawh-Martinez. Today, we welcome our guest discussant, Dr. Babak Mehrara, an expert in lymphedema from Memorial Sloan Kettering. We'll be discussing an article by Mihara et al. From University of Tokyo entitled Multisite Lymphaticovenular Bypass Using Supermicrosurgical Technique for Lymphedema Management in Lower Lymphedema Cases. The purpose of this study was to investigate clinical evidence on the effectiveness of LV bypass in lower limb lymphedema. The authors performed a retrospective review of 84 patients, 162 limbs, with lower extremity lymphedema treated with LV bypass. They evaluated limb circumference, subjective symptoms, and frequency of cellulitis in their outcomes. Table 1 shows the patient characteristics. The majority of the patients were clinical stage 2 lymphedema, or stage 1, that were stage 3. The post-op follow-up period was about 18 months with a range of 6 to 51 months. Based on limb circumference, the authors concluded that 48% were classified as improved, 27% were classified as stable, and 25% were classified as worse after surgery. The mean change in limb circumference was negative change of 2.28%. When you look at figures 2 through 4, they show a correlation between post-LV bypass limb volume reduction and lymphedema staging. And interestingly, these results suggest that the reduction in volume was more significant in cases that were initially advanced stages of lymphedema preoperatively. When you look at figure 5, the authors show that the number of bypasses correlates with a greater change in limb circumference. That the change is cut off once the number of bypasses exceeds 8. They also noted that the improvement in subjective symptoms was noted in 62% of patients. There was no change in about 35% of patients, and 4% of patients actually experienced an exacerbation of their symptoms. A total of 8 patients stopped wearing their garments postoperatively. Postoperatively, the mean occurrence of cellulitis was significantly decreased from 0.89 occurrences per year to 0.13 occurrences per year. So overall, the authors concluded that LV bypass is effective for lower limb lymphedema, but they acknowledge that there is a lot more research that is necessary to further delineate the proper candidates for this surgery. So we now just turn over the discussion to Dr. Mehrara. I'm curious what your thoughts are on this paper, considering your extensive experience.
Well, this is one of a series of papers that have been out by Dr. Mihara and his colleagues. And by the way, that's Mihara, and my name is Mehrara, so it's different. And I think, I think it's an interesting paper. I do have some issues with the paper because I think that, to me, there were some methodological issues that, I'm not very clear on. For example, I don't really understand the circumference change rate that they're talking about. That's not a typical thing that we present. Most people, when they look at this, measure volumes and then compare the differences over time, either with the operated leg or with a contralateral normal leg. And presenting this change rate to me is a little bit cumbersome because it doesn't really make sense. If you look at their methods, they talk about measurements, multiple circumference measurements, and I don't know which one of those was used to calculate the change rate. So it's a little bit unclear. A change rate of 2% doesn't sound a whole lot. The other problem with talking about change rate is that there's a time component to something that you discuss as a rate. And in their formula that they present, there's no time present. So is it 2% per year? Is it 2% per month? Is it 2%? What is it? So I think that method, they could definitely do better. A very simple way would be to measure the limb volumes either using the truncated cone formula or a parameter, which is what we do. Obviously, volume displacement is another, and then calculate the absolute changes in volume over time. I think that would be a much better and much more meaningful way to evaluate this. So I think that's point number 1. Point number 2, I'm glad that they asked the patients subjective questions. However, there are validated questionnaires for lymphedema nowadays, and I think it would be much better if they used one of those validated questionnaires because the way you ask the question can change the patient's response, and really not using a validated questionnaire nowadays is not a very good way to do things when you look at outcomes. So I think that would have been a much better way. Obviously, this was a retrospective study, so maybe that wasn't available to them at that time, but maybe going forward they can do that. And then finally, the last point, the correlation between more severe lymphedema and improving success rate of LV bypass is contrary to pretty much everything else that's in the literature. And if you actually look at the lymphatic vessels, and they have done this, they have a very nice paper that was published in PLOS ONE in 2009, which they refer to, but they don't really discuss with their NEST classification. But if you look at those vessels, over time, the collecting lymphatic vessels, which is the pre-collectors and collectors, which is what they're connecting, those become more and more sclerotic. So if you have a patient with stage 3 lymphedema, say, those vessels are really non-functional. And so it doesn't make a whole lot of sense to me that those are the patients who responded the best to lymphovenous bypass. So I think, this paper probably brings up more questions than it answers. To me, I don't think it sort of solves the question. I think that going forward, there's lots of new techniques that we could use that could be better. I think a validated questionnaire would be great. Measuring volumes and not circumference would be a better way to do this. The authors have tremendous experience with indocyanine green lymphangiography, and it would be really interesting to see ICG changes pre and post-op, because they classify these patients based on that. And it would be interesting to see if their ICG classification changes as a result of their LV bypass. So those would be my suggestions. I'm sure they're thinking about it because these are very, very smart guys, and they're really at the forefront of this type of surgery. But I think it's a good start. Lots more questions to answer.
Well,
Dr.
Mihara, obviously, I'm sorry. Go ahead.
Oh, go ahead, Sam. No, go ahead. You're fine.
I was just going to say it's obviously a very exciting time as lymphatic surgery is coming into the forefront. We're understanding more. There's more studies coming out. I'm just curious, what do you tell your patients when they come to you and say, Dr. Mehrara, what's the difference in outcomes in your experience and in the literature between lymphovenous anastomosis and lymph node transfer? How do you compare the two very bluntly for a patient when they ask you about it?
So, the way I think of a lymph node transplant is lymph node transplant is really a physiologic lymphovenous anastomosis. So, in other words, you're using physiologic changes to cause multiple lymphovenous anastomoses to happen. You transfer the lymph node, you have expression of lymphangiogenic cytokines. Those cause lymphatic vessels to grow into the lymph node, and then that causes some shunting of the fluid from the lymph node into the high endothelial venules, or at least that's what we think. So that's how I think of it. I don't really compare them head to head. I think that LVB, most people think that lymphovenous bypasses are best for patients with early stage lymphedema who don't have lymphatic vessel dysfunction. So I don't really think it's a fair comparison to do that. I think that patients with this late-stage lymphedema, I think of lymphedema as organ failure of the lymphatic system. When you have basically end-stage cirrhosis, it's not going to reverse if you remove the inciting toxin or virus. And I think it's the same thing with lymphedema. Once you get to a point where you have end-stage fat deposition of the leg, it's probably not going to reverse. So I'm curious to see, what mechanisms they have for their findings, and it would be really interesting to talk to them about it.
Yeah, I found it interesting. I mean, it was a smaller component, but that they did have a decent amount of stage 3 patients. And at least from what I've kind of been taught, the higher stage patients tend to try to do lymph node transfer. And they mentioned in their paper that patients who underwent alternative surgical treatments, but they don't mention how many patients ended up needing these alternative surgical treatments. I think that would be interesting to know how many patients got a different therapy and what exactly was that therapy that was offered to them, and did they tend to be these later stage patients?
Yeah, in my experience, patients with stage 3 lymphedema don't benefit from any kind of physiologic procedure, really because I think the entire lymphatic tree has been shot. In those patients, I generally offer a debulking procedure.
Okay.
Yeah. And that's the one, I think that just to pick up on that aspect of this, I think that's going to be sort of the big crux of this paper, right? It's really sort of challenging or presenting data that's contrary to what is out there. And I wonder how much of it, just looking at their figures in the pre and post-operative images of these patients, it probably depends on exactly how far out these pictures are taken, but there is, a visual change in the severity of it, and then the patient.
Right, but if you look at the paper, there's no statistical analysis, so there's
correct.
None of this is statistically significant.
Right.
I can search through hundreds of patients and find one or two who had a good response. So I think we have to get away from this kind of research, which is sort of just looking and doing case examples. I think we need to do a rigorous statistical analysis. We need to be able to measure volume changes and not just measure rate of circumference or something that's sort of
right.
unidentifiable. And I think we have to use validated questionnaires when we report on outcomes.
And I think we totally agree. The only point I was going to make is really that, I wonder how much of it is a limitation in their measurement of, sort of the milder cases versus the larger cases where, these changes in circumference. And their mild cases are actually very mild, sort of on the almost normal range, at least in my inexperienced eyes, that, I wonder if it's just the limitations of how they're measuring these changes, like you're saying. And I wonder if, when we look at the volume, if that'll change how, the results and the conclusions that we're seeing here. But, it's one of those things that in my mind, I totally agree with you, Dr. Mehrara, about, sort of the end-stage disease. I think that's how we're taught it here as well, and that makes perfect sense. But do you think, as you're saying, if there's a different mechanism, is there a role for the potential, I'm totally just advocating here, of there being some, not full-on disease, where there's still some potential, moderate functioning, albeit at a lesser degree, of the lymphatics in, stage 3, let's say, patients. And if you do the bypass, that could still have some functioning. I know we haven't really seen that borne out in the data, but do you think that that's a hypothetical possibility?
Well, honestly, when I do an ICG analysis of patients with stage 3 disease, I rarely, if ever, see a functional lymphatic vessel. Mm-hmm. In other words, I don't see a vessel that takes up dye, nor do I see any pulsations in those vessels. I generally see dermal backflow in the skin, and really that's about it. So, they did ICG analysis on every one of these patients. It would have been nice to be able to see some representative figures of those, because I think that would be nice to see. I don't think that patients with true advanced stage 3 disease have functional lymphatic vessels. I think most of those lymphatic vessels, at least in various regions of the arm, have been destroyed. Now, there are some cases where I see patients whose hand is spared, for example. I'll see a very swollen forearm, but not a particularly swollen hand. And in those cases, actually, if you look at a hand, my colleague Joe Diane is writing this paper, you'll see lymphatic vessels that are preserved. And maybe in those cases that would be helpful. But in my experience, patients with stage 3 disease very rarely have functional vessels that I can see on ICG. And we use the same camera.
Right. No, it's a great point. And just one quick question. I know we probably have to wrap things up, but in thinking of it mechanistically, if it is end-stage sort of organ failure to some degree, which I think is perfectly reasonable, how do you think about it when it's a unilateral limb, for example, without surgery, without an antecedent reason, for it? Should it not be all lymphatics? Do you think it's a genetic predisposition that's leading to this?
I'm sorry, I don't. What do you? There's lots of reasons why people get lymphedema. That's obviously the surgical injury is a big part, but then some people develop lymphedema and others, meaning that there's probably secondary events that regulate it. So what those secondary events are is what we study in the lab, and we have a pretty good idea of what that is. It's an inflammatory reaction that happens from the lymphatic fluid that's sort of sitting around in the tissues. There is definitely an element of genetic susceptibility. There was 2 papers published by the Pittsburgh group showing that. And people with low baseline lymphatic function are at much higher risk for developing lymphedema, so we know that also. So there's lots of things that can lead to lymphedema. Obesity, for example, decreases your baseline lymphatic function. And so I think, there's a lot of papers out on that topic. I don't know how it relates to this particular paper, but, I think there's lots of different things that can sort of lead to lymphedema. The question of why some people get lymphedema and others is really the thing that we've been most interested in.
Great.
All right.
Thank you so much.
I think we need to wrap it up, but thank you. That was a great discussion.
That was great. Thank you.
Sure.